Perfect. I was asked to talk today about advanced preclinical models. And of course, I am biased. I am going to talk about this from the perspective of a neurosurgeon. Here are my disclosures, and hopefully we will be able to go through these learning objectives. What is the role of the neurosurgeon? I think many of us are familiar with, in regards to tumor resection, that we want a diagnosis. We also hope to improve neurological symptoms, such as seizures or deficits with language or motor skills. And of course, we want to improve survival. But I don't think that people are cognizant of the role that neurosurgeons perhaps can play in regards to helping develop research models, as well as precision medicine, and then even to address disparities. And I'm going to show a little bit about how we can address disparities through what we do in the operating room. And it'll make more sense in a little bit. So when I started at Arkansas, there was no brain tumor biobank. So that was something that I instituted, and it's very important for preclinical models. So this is a paper that came out of my lab, written by Dr. DeHeeg. She is the postdoc in my lab. And so what I kind of think about is that there are two sides in regards to what we do when we send tissue. So we send tissue to the pathologist, and that's for diagnosis. That includes histopathology as well as next generation sequencing. I've heard some of the earlier talks where molecular characterization is now integral to defining brain tumors. Also, I think that regionality and what you send to the pathologist impacts the grade of the tumor. So in this picture in A, you can see that this tumor only has a very small region that is enhancing. I actually sent these regions separately, and less than 5% of this tumor actually is high grade. The rest is a lower grade. And of course, the high grade region, that less than 5%, dictates the treatment and dictates the diagnosis. When you're in an operating room, you have control over regional tissue, taking tissue from different regions. There are a lot of different groups looking at the enhancing core versus the flare, surrounding flare. What about harvesting cells near the subventricular zone to enhance glioma stem cell culturing afterwards? And how are we taking out the tumor? Are we cauterizing the tissue, or are we providing fresh tissue that hasn't been cauterized? And then also thinking about intraoperatively, how are we storing the tissue before it's sent to the lab? Does that impact downstream protocols? And can we help with those downstream protocols by perhaps mechanically disassociating the tissue in a certain way before it gets to the research lab? And this nicely translates into developing patient-derived models and understanding the disease further. So here's our workflow. Preoperatively, we do consent all of our patients for tumor banking. We also consent them for next generation sequencing. That includes a panel of about 600 genes and also a transcriptome. We do use gliolin for our glioma, high-grade glioma cases. And in certain circumstances, we use gamatile, which is a form of brachytherapy. In surgery, we do a variety of surgeries, from biopsies to traditional craniotomies, and then also endoscopy, both through the nose or intraventricular. All of these pathways listed, you can obtain tissue. And then with the tissue, obviously we're going to send to pathology. We never want to compromise the diagnosis. But what about a real-time diagnosis? And what I mean by that is not just a frozen section, but what if we can get to the point that we are sequencing in real time during the actual surgery and getting information back? And then what if we were to send the tissue out for drug screening? And we'll talk a little bit about 3D Predict. And then lastly, how does what we do in the operating room affect our research models? Postoperatively, we hope that we help the patient with diagnosis, and then also can we provide them precision medicine? So here's a modern neurosurgery OR. This is a recurrent GBM. This patient has gliolin. You can see that pink fluorescent glow. We tend to use the NICO device because this allows for us to have non-thermal intraoperative mechanical disassociation, as well as temperature regulation when we store the tissue. And we also use connectomics, which is basically very advanced tractography to look at neural networks and to make sure that we enhance our oncofunctional balance. So in regards to research, typically in surgery, it's talking to your pathologist. We always want to make sure that we have diagnostic tissue and that we're sending appropriate regions, like I mentioned in that case earlier, to the pathologist so they can make the correct diagnosis. We also are working with our scrub, and if you use the NICO device, perhaps the rep, here you can see in the tubing all this tumor tissue and how we can do certain things with fluids or with temperature to preserve that tissue. And then lastly, we have to take this tissue out of the OR. This is a nice container that is actually sterile that gets sent to the lab. And this again is our workflow, and we're happy to help others develop similar workflows. So you can see in the top left here, this is traditional just chunk of GBM. That's typically what you can get. But if you use the NICO device or other devices, you can actually just get mechanically disassociated tumor rather than a big chunk. Obviously, many people do various types of protocols in order to further perhaps chemically disassociate these tumors. And then you can grow tumors in 2 dimensions or 3 dimensions, as well as in this case, we actually just took a mechanically disassociated small piece of tumor and put it into culture. And you can see this is a GBM. So you can see that beautiful invasive pattern ex vivo. Again, we only are sending research if we confirm we have enough for diagnosis, because that is first and foremost something we never want to compromise. So what is precision medicine? Basically, traditionally, what we do is we give everyone the same treatment, but that may not work for all. And how can we predict what works for everyone? Classically, in cancer, that is based off of genomics and trying to identify actionable mutations. But functional precision medicine goes a little bit beyond that. Currently, the largest precision medicine trial was NCI Match. And in this trial, they found patients from all various types of cancers who had DNA actionable mutations and gave them a targeted therapy. If you look at these post hoc analysis coming out from different cancer subtypes, you can see that less than 30% of patients responded to the therapy. So just because you have the mutation does not mean that you will necessarily respond. What functional precision medicine does is actually test directly on the tumor tissue and on the cancer cells. This is not a new concept, but what is new is now we're in modern times and we are way better at culturing cells. We also have genomics, transcriptomics. We just heard a talk about metabolomics. So now we are better suited to potentially predict drug response. We also have artificial intelligence, et cetera, et cetera. So maybe now is the time to consider this. We were involved in the 3D Predict trial, which is a trial, multi-institutional trial, wherein we took high-grade glioma tissue, sent it to a company that grew spheroids, and then performed an ATP-based assay to get out a readout for us. And what this looks like is this. They screen for up to 12 drugs, and they give you back this clinical report that shows you response for these various drugs. How can this be used clinically? So this is work published last year at the ASCO meeting. This is looking at temozolomide responders. So in this, you can see that the test was able to predict responders to temozolomide, and then also predict non-responders. And it appears that the test can correlates with progression-free survival. What about patients who are unmethylated? So these patients typically are just thought to be, all of them to be non-responders, but we know clinically that's not necessarily true. We also know MGMT is not done the same way at each institution. So MGMT also isn't black and white. Sometimes you get a moderate or intermediate methylation, and you don't really know how to interpret that. So here in these unmethylated patients, there was just a portion that were found to be responders, and this correlated with their progression-free survival. So this is promising work that perhaps this test can help stratify patients. And again, it is dependent on having adequate tissue. So you can see on the left here that this is not forming a spheroid, and then on the right you can see this tight spheroid, and this is a spheroid-based assay. So if you send tissue that perhaps has too much necrosis or is in a certain region that the cells are more senescent, you actually won't be able to get readouts from this assay. So something to keep in mind, and something that is controlled by the surgeon. So this case is a patient who came in with newly diagnosed renal cell, multiple enhancing brain lesions. We weren't sure, is this metastasis versus a high-grade glioma. Did a biopsy, unfortunately got a lot of bleeding, so at some point had to stop. But from the tissue samples we had, unfortunately, the final pathology came back as glial proliferation. This is not very helpful to the patient. However, we send next generation sequencing on all our patients. 2 weeks later, came back with a TERT promoter mutation. Then it got upgraded to GBM. So what does this show us? Histopathology did not make the diagnosis. Next generation sequencing did. And again, current standards of most next generation sequencing methods take about 2 weeks to come back. We think that that could be definitely an avenue to explore, to improve upon. In my lab, we're interested in long read sequencing, also known as third generation sequencing. And in this, you're able to actually read off of the naked DNA without actually doing any amplification, or for methylation, without doing any bisulfide treatment. So in this paper, what we did is we actually cut out molecular markers we were interested in with a Cas9, and we chose IDH and MGMT just as proof of principle. We were able to cut these regions out from fresh or frozen tumor samples and do the sequencing and get results within 48 hours. This is also important for trial stratification. Sometimes just waiting to get the results back before you can randomize your patients can take a while. This looks, in regards to the IDH mutations, looks to be comparable to current other standards of sequencing, such as Illumina. And where it really outperforms Illumina is in regards to epigenetics. So here we are looking at this methylation at the MGMT promoter region, both the exon and the intron. You can see how beautiful you can look at multiple CPG sites. You're reading along the naked DNA without doing bisulfide treatment, and this gives you back a lot of information. So very promising. Ideally, this can be done on fresh tissue, but you do need a certain amount of tissue because you're not even amplifying the DNA to read from, I call it the naked strand. You can analyze both DNA, RNA, and get epigenetics. And there are some places that have improved the protocols to the point that they're getting reads done within the same day. So, there was a group in Oslo that showed that they were doing this within about 3 to 4 hours, sometimes giving intraoperative information back to the surgeon. This is very useful for pediatrics, where they were able to give back a pediatric neurosurgeon the medulloblastoma subtype. And now the surgeon can decide, do I go for a full resection and risk deficits? Or now that I know the subtype intraoperatively, I can stop, and I know that my resection will not actually benefit the patient, and I'm not going to risk perhaps a deficit. So again, just a reminder, gliomas are very complicated, and it's not histopathology anymore. This is what we're looking at, a very complex, this is from the 2021 WHO guidelines. Now, so this patient is a 24-year-old patient who came in with headaches, has this large enhancing tumor. He had a history of colon cancer at age 3. I took him to surgery, was very happy with the resection. He also didn't have deficits. He underwent classic chemo and radiation, comes back within 3 months with local recurrence. And you can see circled in yellow an area that our radiologist noted on the opposite side along the dura. He wanted to do everything possible. He was very young. I took him back to surgery for the local recurrence as well as this dural base enhancing lesion. We were suspicious this was recurrence, and that was correct. So I was at quite a loss because this is someone who's recurrent after adjuvant chemo radiation within 3 months. What did we learn from this case? So we're still learning from this case, but what we learned in real time was that thankfully we had sent off his next generation sequencing. We do send germline sequencing, and we found out he had Leaf-Romany syndrome, which was very helpful for his family. And we typically, with our brain tumor bank, we identify patients every year with cancer predisposition syndromes. This is very helpful for their families. But the other thing is he falls into this group that we did a targeted DNA panel, and there was nothing actionable. He doesn't have an actionable DNA mutation that currently has a targeted therapy available. So now we're in a predicament where this is a 24-year-old male, no neurologic deficits, wants to live as long as possible, but has this really terrible tumor. So this case inspired us to work with a group out in California, as well as my local collaborators down here, Dr. Reed and Dr. Oath, in order to combine transcriptomics and organoid modeling in order to find a treatment for a patient. So one thing that we did is we looked at the RNA of this patient, and this is a tumor map similar to a Google map where each dot represents a cancer. And if they cluster together, that means they're more similar. So his tumor was quite unique. Can see that his tumor had features consistent with ependymoma as well as low-grade glioma and GBM. However, no tumor had greater than 95% similarity to this tumor. We ended up doing comparative transcriptomics, which means where we take the bulk RNA and look for gene expression outliers and identify pathways that potentially have FDA-approved drugs that can target that pathway. And then what we did is, in my lab, we had his tissue. We developed an organoid system where we can actually screen those potential targets. So here is the patient of interest. And one, we did his comparative transcriptomics, which identified that the JAK-STAT pathway was an outlier and potentially could be targeted with the drug ruxolitinib. We also took other patients from our tumor bank and found what potential targets they had. Some we wanted to compare to several other patients, one who also had patient 23 who also had a target in that same pathway, and then 2 other patients that did not. We did dose response curves on their ex vivo organoids, and that we found, interesting enough, that ex vivo, when we gave ruxolitinib, which inhibits the JAK-STAT pathway, that as predicted by the transcriptomics, patient 1 and 23 had the best dose response curves, whereas the other patients did not. During this time, the patient ended up having further recurrences, and he had tried multiple targeted therapies. At this point, we were thinking of trying a drug combination, and we tested both ruxolitinib as well as everolimus. He had a TSC mutation, so we thought that this may be another target. We tested his first tumor as well as his most recent recurrences and got dose response curves, and then ended up treating the patient with this combination based off of our lab work and just asking him if he wanted to try it. Thankfully, he did. This was his longest progression-free survival. He had 4 months of progression-free survival. At this point, he was having recurrences about every 1 to 2 months. And so this was very exciting for us. The other area that we feel that surgeons can have a lot of utility is actually obtaining surgical tissue in unique situations. So in this patient had a gliosarcoma, which is a glioblastoma subtype, very aggressive, with confirmed metastasis to the lung. And we were able to excise that tumor. And we were doing it actually for functional precision medicine purposes. But thankfully, this patient also donated their tumor tissue to research. And so now we're analyzing this tumor tissue to try to understand how is this possible that glioblastoma can leave the brain and what mechanisms drive that. The other thing that we're doing is developing better models. So invasion is the bane of my existence because we know at that border, that's where you get those invasive cells that just hide out, are resistant to chemo and radiation, and invade into the surrounding normal brain. So here we're using a patient-derived organoid system where we're actually testing invasion into a matrigel extracellular matrix and testing various drugs to see if we can inhibit invasion over time. We also can grow a mini brain, where this is using stem cells and actually inducing a small embryonic-like mini brain. And then you can add tumor cells to that mini brain so they have an organotypic microenvironment. And then you can do drug screening. The last thing I just want to briefly touch upon is surgical strategies to address disparities. I obviously live in a rural state, and we found, not surprisingly, when we were studying our brain metastasis cohort, how terrible our patients do when they do not get postoperative radiation. You can see that in red. This Kaplan-Meier curve is terrible. They're living way less than a year. This is obviously something that we all know how imperative it is that after you get surgery, you need adjuvant radiation. One thing we're considering is in those patients who are at risk due to their rurality or other socio-demographic factors to implant brachytherapy at the time of their resection in order to make sure that they get that adjuvant treatment that they need. So we think that may be a way to address disparities. So we hope that I hope that this talk was helpful for people. This does take a lot of resources. You have to actually implement a system to incorporate preoperative consent. You also have to establish a protocol and work closely with your neuropathologist about how you're going to manage intraoperative tissue. And you need personnel, which can be expensive. Lastly, you need a place to maintain your biobank if you choose to use tissue for research purposes. You also need a neuro-oncologist who's willing to interpret those findings and believes that that may be helpful, because you can give them that assay, but if your neuro-oncologist doesn't buy in, it won't actually drive the patient care. So future directions, we really do think that we're going to move to real-time diagnosis. It would be awesome if we just get diagnosis information the same day, not only for clinical trial randomization, but also for intraoperative decision-making, and then standardized surgical protocols so we can reproduce preclinical models. And then we need to validate these organoid assays and continue to use our patients to understand disease progression and treatment resistance. Thank you so much.
Thank you, Dr. Rodriguez. As always, a scientific tour de force, and it makes me feel not particularly intelligent when we have people like you coming to speak. I'm curious, I know you and I have talked a little bit before, but wondering if you could share with us some of the things you've done to mitigate issues around successful tissue collection after hours and on the weekends, which I think for many centers is a problem.
Yeah, absolutely. So we have had the Friday night case that goes past 5 p.m. many a time, or at, even other weekdays. I think the Friday case is the most difficult because it's not until Monday that you are probably going to have staff again. So we have used a certain type of preservation media. I forget its commercial name, that we have been able to preserve tumor tissue that came out Friday night until Monday. We've also had other things happen like snowstorms and ice storms that have prevented when we sent 3D Predict. We do tend to send more tissue when that happens, when we know there's going to be a delay and they're not going to get it the next day. And we've had successful spheroid formation sending something on a Friday that didn't get there until Monday or Tuesday. And that was mitigated by sending extra tissue. We also do believe in gliolin, that sending metabolically active tissue and not areas of necrosis. So when a test fails, when the company tells me it fails and they're like, oh, maybe it was necrosis, maybe, and I'm like, no, I know what I sent you. I'm sending you good tissue. We're sending you, this was not necrosis. I was near the ventricle. I'm trying to like totally optimize what I'm sending you. So what is the other reason? And there's actually, I won't get into all the reasons, but there are other reasons for failure. But what we can do is regionality, make sure we're not sending necrosis, and send a bigger chunk than you typically would when there's that delay, and then certain preservation media.
Great, thank you. All right, moving on.